Our next presentation features Lisa Gallagher, the Senior Director of Privacy and Security at HIMSS, and Bob Krenek, the Senior Director of Experian Data Breach Research. Lisa is has always been a big help for healthcare IT news, and she's just a go-to person for privacy and security issues. And she also helped with the programming for the forum, so I'm really appreciative for her efforts in that. And Bob Krenek, basically the Experian, the sponsorship of this report, it's also supported by the Medical Group Management Association, and Experian is a leader in helping companies plan ahead for a breach of data or to help you navigate the storm if one occurs. The annual HIMSS, I think the interesting thing about the HIMSS survey is that Tim looked at privacy and security from a big picture perspective. Now we're going to get right down on the ground level and look at the data regarding facilities, how much money they spend on, how much they budget for privacy and security, the resources they devote to it, the dedicated staff, key concerns of healthcare facilities, and how facilities are handling new meaningful use requirements. So I'm going to turn it over now to Lisa and Bob. Thank you very much.
HIMSS had done a small survey about HIPAA compliance, but really I couldn't get a handle on where folks were. So we decided to create this survey. So this is our 5th annual security survey. So that enables us to do several things. First of all, each year we trend the data year over year, so we'll be able to tell you a little bit about what improvements are made year over year. But this year we also took a look back at where the data was 2008 and where it is now. And Bob and I will be going over the actual data and some of the trending and some of our observations as well. The survey is being released today, concurrent with this conference. So the report is about 60 pages long, and there's so much information in there that we can't possibly cover it all in 45 minutes. So we've decided to give you some highlights and insights. But I would say if you really want to look at the detail, go to our website and download the report. And of course, Bob and I and our organizations will be available for questions and to help you sort through it. We really try each year to make the data valuable both to the industry at large as well as to each individual organization. So very often I get questions that sound like, well, I really want to know what my peer organization is doing. What security controls seem reasonable to them? What technology are they currently using? What are they planning on using? What's working? What's not working? So we sort of formulate the questions so that individual organizations implementing security can get benefit from it as well. So the way we're going to do this today is Bob and I are going to present together. I'm going to give you the data, and Bob, who works in security breach area, security breach remediation, is going to give some observations on what he sees in the data as well as what he sees out in the industry as well. Yep. So our learning objectives are here. We're just flipping. Nope, I'm not flipping. I don't know what I'm pointing at.
Tell you what, let me, is it coming off your computer or one up there?
Up there. Yeah. Let's try that. That work? Yeah.
Yep, there we go.
There we go. There's Bob and Lisa. Learning objectives. Okay. A couple of things about the survey. And actually, I'll go to the next slide because I think this is important to note. The way that we execute this survey is that we try to get to, within each organization, the actual person, an actual person who is responsible for security in their organization. So we don't put a web link up and just let everybody in the world respond, but we go and we try to get to the actual person who has responsibility for a couple reasons. One, we think we'll get more accurate data. Two, we don't get a lot of don't know answers that sort of skew the data. About 3 years ago, we decided that with the HIMSS database, we were getting a large portion of hospital organizations, and we wanted to include medium to small practices. So we started a partnership 3 years ago with MGMA, who has helped us reach into the medical group practices that are their members. This year we had 303 respondents, and again, they're all in a role that is responsible for security. Okay, so the first area that we'd like to probe, I kind of threw this in at the beginning because I thought it might be interesting, and it's turned out to be one of the most important pieces of data that we can look at. And that has to do with what is the budget and staffing and resource levels that are assigned to security, and have they changed over time? So we do see organizations saying that their security budget has been increasing. However, over the last 5 years, we see a significant portion of the organizations who say that their security budget is between 1% and 3% of their total IT budget. We actually have pushed on this number a little bit. I actually testified to an HHS hearing on this number. They wanted to know, why was it so low? What should it be? How is it compared to other industries? And Bob will talk about that. There has been some increase. There have been organizations that are creeping up beyond 3% to the 4 to 6% range, et cetera, but still a pretty concerning number. So I don't know, Bob, if you wanted to add
just
to
to
that.
make a quick comment around that, and just from what we've seen out in the market, that actually is quite a low number. 1 to 3% to protect very valuable information is quite low. And I think speaking to the presentation earlier today, that we've got to get a commitment, and part of it is building a culture within the organization to get funding for it, and then second is get to the board. If you can get to the board, they understand it, and quite frankly, they're at risk as well. So it's not just the organization, but I mean, there's a lot of people who could go to jail if somebody comes after them and says you had inadequate security around patient information. So what is the right number? I've heard estimates that basically run around 8 to 10%. When you look at the financial institution arena. But again, you just need to go out and do your research. Bottom line is you just need to get done what needs to happen to protect the information.
So in the second major bullet there, some good news. We ask our respondents whether they have any full-time staff or are named CSO assigned to security. And while in 2011, we had half of the respondents saying so, this year that number rose to about 2/3. So looking at some of the data, and we won't spend too much time on this slide, but this is where you can see that, again, the majority are in the 1 to 3% or 1% and below range. But we did see some increases in organizations reaching the 4 to 6% range, and even in the 7 to 12% range. So that's quite encouraging.
Yeah, and I think that's the good news is people are making some strides. So it looks like you're dropping in the 1 to 3%, but those people are starting to move up into the 4, 6, and 7 to 12. So some good progress there, but a lot to be made. Probably the other thing is I think we're going to see this increase drastically over the next couple of years just due to all the HIPAA regs and the fines that go around it. And I think, unfortunately, it usually ends up being that somebody gets fined, hit with a multi-million-dollar lawsuit, and then they go in and make the changes. So it's either pay me now or pay me later. I would rather take getting hit, not getting hit with a lawsuit and address it up front.
Okay, so moving on to the category of risk assessment. So as you can imagine, over the last 5 years, this has been a big topic within the industry. It elicits a lot of interest from the government, both in ONC and OCR that enforces HIPAA, and now with CMS with the meaningful use requirements. So we've continued to look at whether organizations actually conduct a risk assessment, and if they do, how often do they do that? So combining the numbers of the hospitals and the medical practices, we have an average number of 71% reporting that they actually do a risk assessment and do so annually. We have some detailed data that we've asked about what do they do with the risk assessment information. So once they're done, do they do anything with the information, and what are the things that they do? So that'll be on a subsequent slide.
Yeah, and just again, looking at this from a hospital or physician practice, I think as far as a risk assessment, it should be done a minimum of 1 time per year. Best practice would probably be 2 times per year. Technologies and things are changing, the way hackers enter into systems, et cetera, are changing. So to me, risk analysis, it should be something that is done at least 1 time per year.
So if we look at the 5-year trend data, we do see that the numbers are increasing for hospitals, a little still concerning for medical practices this year, 65% reporting that they did a risk assessment. And you know, if we relate that back to the fact that any medical practice that's applying for meaningful use incentive payments cannot meet the requirements if they're not conducting a risk assessment. So, you know, our expectation is this number will continue to rise, both with regard to the fact that HIPAA enforcement will be more visible, as well as this is becoming a core requirement for meaningful use, and will stay that way going forward.
Yeah, and just as a note, as you can see, what was it, 90% of the respondents working for hospital conduct a risk analysis, 65% for the smaller practices. And again, I think that comes down to budget and resources, and you know, I think that's a little bit tougher way to plan and to figure things out when you've got the limited budget and limited resources. A lot of them don't have, you know, chief compliance officers, et cetera. So again, these are all things that need to be worked on.
Right, and Bob makes a good point. We have linked the risk assessment number in the past to the amount of budget that's allocated to security, and as that number rises, so has the number of organizations actually conducting the required risk assessment. Okay, I'm going to take a little aside here. HIMSS Analytics maintains a database with IT data from over 3,000 hospitals across the United States, and so we went in there and took a look at their response to a couple of security questions. There's not a whole lot in there, but there was a question with regard to risk assessments, and that was entered into that database when it became a meaningful use requirement. So the question in the database, the information that we elicit in the database, is worded according to the meaningful use requirement, which says 2 things. 1, you need to do a security risk assessment, and 2, you need to actually take action and mitigate some of the areas of risk with some adjustments to your controls. When the question was worded that way across all the 3,000 plus hospitals, and also knowing that it wasn't necessarily the security person that's answering the question, we got 46% of the hospitals who responded to that question and were actually doing a risk assessment. And at the higher stages of the MRAM model, HIMSS Analytics Stage 7 hospitals were still around 53%. So these numbers are a little lower than in our survey, but I think we'll continue to track it in that database as well. So here we ask the respondents that actually do a risk assessment, what do they do with the results? And we ask 3 questions. Do you use that information to determine where you might need to put additional security controls in place where there are none? Do you identify areas where there are security controls, but they may not be performing in a way that reduces the risk to your level of risk tolerance? And then also, do you go back and look at whether your policies are adequate? I mean, is there that cycle all the way back throughout the security program? So basically, are you conducting ongoing security risk management?
Yeah, and just a couple of things that I see here. The great news is you've got, you know, over 90%, you know, they're putting security measures in place. The big disconnect is obviously around the policy, and just as an example, Experian has training, I think it's about 2 times per year now, around the policies, procedures, who to contact, the CISOs, who can touch what data, et cetera. So to me, policy is a big part, if not as important as actually putting the programs in place from a physical perspective.
Okay, so beyond just conducting a risk assessment and what do you do with the results, we asked a few more questions about what we thought were components of an ongoing security risk management program. We asked them if they sort of test or, determine the adequacy of their current IT security plan, and as well, do they have a data breach response plan, and do they test the adequacy of that? And there's some interesting results here. We did break this one out by hospital and medical practice, so you could see the differences in the data as well.
Yeah, and just some things that I see, it says 43% of the respondents test their data breach response plan. That actually seems very, very high to me, and I think probably it becomes a question of what is your view of a data breach response plan in testing? And my guess is that they pull a book off the shelf, they have a meeting on it once a year, and then that's their idea of testing it. To me, that's not the case. I've got a lot of not only just hospitals, et cetera, but retail organizations, large financial institutions that actually come to us and they say, hey, we're going to perform basically a mock data breach, right? And so they actually put their plan to test, and we're part of that. They don't let anybody in the organization know it. And then what they do is they actually set it up pretty nicely. They set it up on a Friday, which is usually when these things happen for some reason. And then on Friday, the call goes out to who's ever, the lead person on data breach. And then the contacts are made across the organization. They're made to, forensics firms. They're made over to Experian. So it's a good drill, and you find out where your holes are. It's much better than just kind of reading through a policy manual.
Okay, so moving on to a new area. We have probed over the last 3 or 4 years as to who the enterprise is sharing data with externally. First, whether they do, and then we actually probe into what external entities they are sharing data with, and also what external entities they plan to share data with in the next 2 years, which I think provides us with some interesting information. So an average of 80% say they are sharing data in some form externally, 90% of the hospitals, 74% of the physician practices. We also ask about whether they're currently sharing electronic data with their patients. This is an interesting number because 5 years ago, it was only 1/4 of the organizations, and this year, 3/4 average across both the enterprises, the hospitals, and the medical practices.
Yep. And one thing that I like to note here is from a data information standpoint, what I call data in motion, the easiest way to protect that data, if you've got data going out, is encrypting it. It's not that expensive to do. It's probably, well, first of all, it's not expensive, and it's probably the easiest thing that you can implement to possibly keep a data breach from happening. So anything that's in motion should obviously be encrypted when it comes to healthcare information. The second thing is that I look at is not only from an outside perspective, but from a data breach perspective, it's not just data in motion that's going outside of your organization, but what about data that's at rest? So the data that's sitting in files somewhere, are those encrypted, or are they just sitting out there, somebody hacks in and can access that data? So don't just look at the in motion, but also look at the data at rest.
And in later questions, we do probe as to current and future use of encryption technology. So here we ask them detailed questions about who they're sharing data with, and we ask about what they're doing today and what they plan to do going forward. You can see that the highest numbers right now are in within their own corporate entity, whether it's an IDN or other large enterprise, and as well third-party service providers, which you could define as business associates and maybe others. And there are also some other observations in the data that I think are pretty interesting.
Yeah, the good news is the data is going to be more useful, more accessible to patients, and I think that's good. And today we're talking about how to protect that. So since it's headed that way, what are we doing to, we need to take the opportunity to protect it. But then the other part that I really see here is now you see that a lot of partner arrangements are going to be increasing in a significant way. And, I heard somebody mention, it was in the previous conversation about, BAAs, getting BAAs put in place. And again, they're about as good as, in my opinion, as the paper they're written on. And I kind of, a little bit tongue-in-cheek and telling a little bit on ourselves, but when we first start getting into the healthcare, we understood obviously that, that we needed to become HIPAA high-tech compliant, and we were not. And the interesting part about all this is a lot of our competitors, right, were signing BAAs, we wouldn't sign them. And so my point being is we share a lot of information. You know, there's multiple vendors that do what we do, and they're signing BAAs, they're getting information from us, and we can't sign them. So they don't even know the people that they're getting information from are compliant. So my point being, and by the way, we are compliant now, but my point being is especially for your larger, you know, as you start to set up these larger partnerships and sharing information, not only get the BAA in writing, but you need to have a security group go out and make sure that they are encrypting and doing all the things that they say they're doing in the BAA.
So if we look at the last column, future sharing arrangements, there's a couple of interesting numbers to notice. Public health entities, 40%, over 40%. We'll plan to do that going forward, but wow, look at health information exchanges. 63% anticipate doing that in the near future. And as well with PHR vendors, over 41%. And almost 45% are participating in the nationwide connectivity in some way. So those are pretty significant numbers. Actually, the HIE number, I think, was a little higher than I had anticipated. So, I mean, hopefully that means there's some optimism about the viability of that business model and the ability to share data. You know, we always hear anecdotally that there are a lot of concerns on the privacy side, and, you know, maybe we don't have the right governance model, and do we know how to do this in involving the patients? But here, you know, it looks like they view that they will be participating in the HIE exchange model, and so we'll track that going forward as well. Okay, sorry about my skills with the clicker. We did want to ask a couple of questions about access control, and the first one we ask is, if you have a portal for patients to access their own data, this is just those that responded, yes, they do share with patients, how do you control access to that? And I'll let Bob add his commentary to the surprising results.
Yeah, just kind of a couple things that I see in it. You know, it says 98% of the respondents that, you know, provide patients with access to electronic information used at least one security tool tested in the research. So, you know, the question is obviously you know, the best is layers and layers of data encryption and layers of protection as far as access to sites, et cetera. So, you know, the question is really how secure is it? And then I still go back, you know, this says 98% of the respondents that provide electronics. There's still plenty of data that's not protected via paper or whatever it may be. So there's lots of improvement, whether it be electronic or paper-based.
So how many of you would say that username and password are going to go away? Because I get that question a lot. You know, when is it going to go away? It's gone away in other industries. Well, look at this data. I mean, they use username and password for everything. They don't use biometrics and don't use hard tokens. When you look at the data about technology that we're going to look at in a couple of slides, you'll see they don't even have any plans to purchase biometrics or any other, you know, multi-layer security controls. Something to think about. We're going to probably try to probe as to why that is. You know, anecdotally, we hear complaints about workflow interruption, and you know, so we do see a high number in single sign-on technology, so that might be related there. But they're using username and password everywhere, and including with this information here on the patient portal. So interesting. Double click. Okay, so a couple of years ago, we added a few questions about what kind of data is being collected in terms of audit logs. Where is it being collected and what data is in the log? Some of this was just curiosity, and some of it was generated by the draft rule that we got on accounting of disclosures from OCR, where we saw that they were requiring accounting of disclosures for patients, but OCR also added a requirement we had not anticipated and was not in the statute, which was a requirement for access reports to the patient. And basically that means any access, including read access, to patient data would have to be logged and put in a report for a patient. We were trying to impress upon OCR that it might be difficult because the type of data that they're looking for isn't always collected in a traditional security log, and also we're talking about a lot of data, both to collect, maintain, put into a report, and give to the patient, but also how would it benefit the patient if they can't figure out where to find, the one access that they're looking for. So anyways, that's kind of the history behind it, but we've probed this for a couple of years now, and we found that 91% say that there is an audit log somewhere, and we wanted to know where. So the highest incidence of having audit logs are on applications, firewalls, and servers. And there is some information collected in some organizations about clinician access and non-clinician employee access to data. But most of the time, the logs are traditional security logs, so they're accesses and security critical events. So I don't know if you had a comment. No? Okay. With regard to what they do with the logs that they do collect, there is a high level of use for policy compliance monitoring, so employees accessing the data when they should and not accessing when they shouldn't, and also this HIPAA requirement to monitor system activity. These numbers have stayed fairly consistent over the 5 years of the survey. Here's just a slide that summarizes what kinds of data is collected. Clinician access to data is increasing, and we think that might be because of the possibility of an access report requirement when the accounting of disclosures rule is finalized. Let's see, I'm moving to the next slide. So here's the complete list of the systems that we ask them if they have a log attached to it. And again, applications, firewall logs, and servers, the highest incidence of logging. We asked about some of the other clinical systems because we wanted to understand if there were any sort of log attached to those, knowing that if the access report requirement is retained, that we would necessarily have to have data from those logs aggregated with the EHR log and all of that data presented to the patient. And you can see that within some of the other systems in a typical hospital organization, the incidence of having any sort of log attached to that is pretty low. So we wanted to collect that data to understand what the challenges were going to be for the industry in meeting that requirement.
And just a quick comment on that, something that really surprised me, that the intrusion detection systems, only 56% had the log set up for that. And that's just incredible to me, that you're not looking for somebody to actually penetrate your system. So again, and one other thing, and I may mention it a little bit later here again, is it's not just detection as far as coming into your system. People can get into the system, but the question is what information is going out as well, and you should have systems in place to detect that as well.
Okay, so we asked specifically about the technology tools related to security that are being used in organizations now. And as you might expect, a very high incidence of firewalls, user access control tools, et cetera. I think we have a future slide that talks about the actual numbers in all of those categories. As you also might expect, log aggregation tools. If you don't have logs, what do you need a log aggregation tool for? Public key infrastructure and biometric technologies are the least utilized. And hospitals have a higher incidence of using any of these tools than do the medical practices. Okay, so when we look at these numbers in detail, a couple of things you can see. The averages are high in some areas. firewall user access controls and audit log access to records in the EHR. The numbers with regard to disaster recovery, off-site storage, et cetera, remain consistent across hospitals and medical practices. And then we have some numbers on encryption. I know Bob wanted to comment.
Yeah, just real quickly on that, again, to me, kind of an unacceptable, you know, if you're looking at medical practices, 55% have data encryption. They also are down in the 36 for intrusion prevention again. Get the data protected. I mean, it's, like I say, you need to have multiple layers, not just one methodology.
This is one of my favorite questions. What security tools are you planning on purchasing in the next 2 years? So you can see that disaster recovery tools are pretty high on the list, and as are the encryption tools as well. Again, biometrics, electronic signatures, things that are a little bit more sophisticated tools are at some lower numbers for going forward.
Yeah, and the only thing I've got, and I mentioned it just a little bit earlier, is on the intrusion invention and detection. Again, it's not just intrusion. Look at what your data is. It's on storage, because a lot of times people can get in, you don't find it, but you might see anomalies in data going out. So it should be protected on both ways.
Okay, so we ask extensive questions about data breaches, and also we ask specifically about medical identity theft. There's a reason behind that. ONC has had an initiative on medical identity theft for a couple of years. We started collecting this data 3 years ago, and it's really, to me, a fascinating area to probe, because it really represents a motivation category. Why is the breach happening? What's the motivator as far as the threat goes? And you know, one thing we found in talking with folks and through the survey is that with medical identity theft, you have a breach, and sometimes the hospital isn't the one that's detecting it. It's the patient that was victimized. And we also find that once that happens, it's reported back to the enterprise, say the hospital. They don't have a real good process for dealing with it. So you may have a situation where you've got a second person's data in a record, and we're going to talk about issues along that line in another presentation later, but hospitals don't have a process for cleaning that up. And they also don't tend to take that threat motivator and wrap it back around into their risk assessment and say, okay, if we know that a lot of our threats from the outside are coming from folks that want the data for particular reasons and then use the data for particular reasons, can we put mitigating controls in place so that whole circle isn't really happening yet? The numbers are reported on medical identity theft tend to be low, and I really think that's because they're not detecting it. It may be more widespread than is reflected in the survey, and again, because it takes the patient detecting it, bringing that to their attention, and they may not even log it, because if you think about it, in a lot of cases, the bill for their services was paid. So it's not really a motivator to go track it all down. You know, but it is a breach, it is fraud, and we're sort of trying to bring some awareness to it. Getting back to data breaches, we asked a number of questions, and we have a couple of slides here. The organizations that have a formal policy and procedure to deal with security breaches, 62% total, and that's an average, so 76% at the hospital level and about half at physician practices.
And just a couple of notes on that, and again, it says, you know, the folks have had a formal policy for data breaches. Again, my question is, has it been tested, or is it just gathering dust? And generally speaking, it's gathering dust. And basically, my point to this is we've handled some of the largest data breaches around the country in the medical field, and a lot of all the fields, actually. And when you have a data breach, your hair is literally on fire, and that's not the time to be testing your data breach plan. So I highly recommend that you get in front of it. And invariably, on just about all of these, they didn't really have a solid plan put in place. And then when you went in and fixed it afterwards, then they put the plan in place and then they tested it. But again, my recommendation is do it before your hair's on fire.
So the number of organizations that have reported having a breach in the last 12 months was at 22% in average across the hospitals and medical practices. Bob and I had an extensive discussion about this because the number seems a little low compared to some other surveys and some other data that's out there. A couple of things, we asked the question over the last year. So there are organizations that had big breach 18 months ago. They would say no to this question. Also, my view is that these numbers are only as good as we are at detecting the breaches in the first place. So just because they say they haven't had one doesn't mean they haven't had one. We asked specifically, again, about medical identity theft. Big awareness challenges here. The number's actually gone down, while we know that the incidences of medical identity theft are going up. So I think it's something we need to work with our member organizations on understanding, detecting, and dealing with.
And I was going to say, just from personal experience and the number of data breaches we're handling this year, I think the number's probably low. I mean, literally, we get calls daily to handle data breaches. Some are small, 1-2 patients. Some are, thousands of patients. So, from what I've seen out there, it's a pretty significant issue.
Okay, some additional thoughts on breaches. So the breach reporting requirements to HHS are that you must report it if it is if the single breach affects more than 500 patients. In any breach situation, 1 patient to 1 million patients, you must notify the patient, but you don't have to report it to HHS within 60 days if it's less than 500. Now, this year I wanted to probe how many of the breaches were less than 500, how many were more than 500, just to get an idea of what might be happening. The number of reported breaches from these organizations that are over 500 is pretty low, 6% on the average. But we know that, I think Tim presented the number earlier, the number of total affected patients so far in the reported breaches at HHS, and these are the ones that are 500 or more, or 21 million patients, okay? And I guess Tim's not here anymore, so he's not in the room, because he probably would fall over when I make my next statement, and that is that the breaches that are affecting 500 or less patients are not counted in that number. They are collected by HHS, so with the breaches of 500 or more, you have to report it to them within 60 days. At the end of every year, you have to report all of your breaches, so whether it affects 1 patient or 10 patients or whatever. They take that data and they put it somewhere, but it's not counted in that on the website that you see. So we've had folks in the industry saying, we really want to know how many total breaches there were and how many total patients are affected. And we're having a little trouble getting that data because it's not required to be reported out by HHS to the public or, more importantly, to Congress. So there's the data that's collected on the breaches that affect more than 500 patients, and then there's all the rest of the breaches. So that my point is, and Tim's still not here so he won't fall over, that number 21 million is, I've had a couple of folks estimate to me they think the real number is more like 40 to 50 million. I don't know, I cannot confirm that, and nothing that I can do in this survey would get us to that number. Hopefully at some point we'll be able to get maybe an order of magnitude, as far as the total number. We did ask a few questions about what do they do. Do they notify their patients? Because they're required to do that. It doesn't matter if it's 1 patient or 100. And 94% said yes. I don't know what the other 6% do. It's kind of scary. And 58% notified the government of the breach. I can't answer what that means, because if it's more than 500, you have, 60 days, and that's it. Otherwise, you can get fined and put in jail. So we're going to try to probe that a little bit more going forward. This is the first year we've asked those sorts of questions. Do you have anything?
Yep. Nope, that's got it.
Okay. And in conclusion, the security budget as a percentage of IT budget is a little increased, but it's still, as an industry as a whole, we're pretty low on those numbers. We do see some increase in the folks doing risk assessments. That's a good sign. We think that going forward, there'll be more motivation to do it with HIPAA enforcement and the meaningful use requirements. Bob expressed very eloquently the concerns about sharing data externally and the kinds of security protections you need to be prepared to put in place to do that, both with your business associates, but also all the other external entities that we mentioned in the previous slides, and with regard to, the exchange environments that we're looking at going forward. And, as we might expect, and as we validated in the survey, the medical practices are a little behind in implementing these kinds of security controls than the hospitals. And this is an area that at HIMSS we're working on very diligently. So I have a slide after this that lists some resources that we have on our website. We have a whole security toolkit for small providers. So we really understand that doing a security risk assessment or doing some other security activities, we can't talk to small practices in the same way we do to hospitals. So every document that we have in our toolkit, we sort of instantiated for small providers so that we could speak to them in a language they understood, that we could scale the processes in a way that was helpful to them. And so, those are listed on the next slide. And we are going to continue to work with the small, medium practices. Also, small to medium hospitals, rural hospitals, critical access hospitals. We also see some challenges there. And I think some of the tools apply to those organizations as well. So again, with the survey, I would say we've only given you a snapshot. There's lots of data in there. And going forward, take a look at it. If you have any questions, we're certainly available as a resource. And Bob, did you have any concluding thoughts?
Yeah, just a couple thoughts. Again, some great information, some information you can take back and digest and share with your particular entity. But I think it really comes back to the conversation in the previous discussion, which was around building the culture within the organization and get the buy-in at the board level, because you can take all this information and digest it and say we've got a problem, but getting things done, it's going to have to come from the top down. And I'm still a firm believer in letting them know what their risks are, not only to the organization, but to them personally. So, I think if by not raising that and bringing it to their attention, some board members don't know, or you might have a good, a solid board where they understand risk mitigation, et cetera. And, like he was talking about earlier, where the bottom met the top halfway, they were both working on the same type thing. So hopefully you've got that, but if you don't, you need to go in and educate the board.
So on this slide is the complete set of privacy and security toolkits that we have at HIMSS. These are put together with a very robust and dedicated set of volunteers from our membership community. So we form work groups and we pull these tools together. There's instructional information, process information. There are sample policies, sample user agreements, sample everything's in there. Usually those are pulled from our organizations that participate, and so they're being used actively in organizations. They're sort of been vetted and tested a little bit. So we have a big toolkit, then we have a toolkit for small providers. We have a patient identity integrity toolkit. We have two fabulous ladies who are going to speak at another panel later in the conference about challenges around patient matching. They've participated in the creation of this toolkit and are helping us drive that issue at a national level. Risk assessment toolkit, mobile security toolkit, and cloud security toolkit.
Lisa, and Bob, the report that you folks just went over, that'll be available for download on the HIMSS.org?
Yes, so it's being published today. There'll be a press release. It'll be on our website. It'll be on the HIMSS Analytics website. It'll be on the Experian website. And there's a press release and some information about it. The full report, there's an infographic that's going to be produced with it as well, all coming out today. So I can't say if you look right this minute, it'll be on there, but it should be on there sometime today. They were actually aiming for right at the conclusion of this panel.
Good.
So we'll see how that worked.
Are there any questions or comments before we have a short break?
Come on up.
Thank you very much, Lisa and Bob. That was really helpful. One of the comments I had was, our question maybe is, what's the correlation, if any, between security spend and success? Because I think a lot of organizations can spend, they're looking for silver bullets, or engineers like the bright, shiny stuff, so they're saying, we need this. But it doesn't necessarily mean the organization is more secure. So I'm just curious if any correlations surfaced from that.
Well, I think 20 years ago, when I first started out in information security, I worked on a project that was designed to develop some metrics to measure success around security. And I'm sure that you all are aware that it's a very difficult thing to measure. Success means incidents don't happen. Success means data is not accessed in an unauthorized way. So that's hard to measure. And I also mentioned earlier that I think that we're not in this industry very good at detecting breaches. So we may not even have a handle on how widespread the bad stuff is. So that's a difficult thing to do. However, when we talk to decision makers in the organizations, CEOs, CTOs, CSOs, CIOs, and even CFOs, we talk about the fact that security risk needs to be rolled up into overall business risk. And when you speak to them in those terms, it seems to make a little bit more sense. And the risks are not just breaches to the data. The risks for a healthcare enterprise are patient safety, they are quality, they are efficiency, they are cost, they are reputation, they are somebody going to jail, they are fines. And so it's almost not a conversation about correlating expenditure to successful security results, because that's so challenging, but it's really more expenditure and bringing down overall business risk, if that makes sense. And that's really the best answer I have. And Bob, do you have?
Yeah, I was just going to add, in addition to the other risk, you've got a set of reputational, and there's been all kinds of surveys on that, and as far as, are you going to lose customers or patients due to the fact you had the breach? So that needs to be rolled into the figure as well.
Yeah, I think that's interesting. I guess, my last comment is I would challenge that, Bob, because everything I read and follow for many years, both in the financial services sector as well as in the healthcare sector, is that consumers are not really driven by the results of a breach. I mean, TJX, major breach several years ago, and they're named one of the top 100 companies based on their revenue expansion by Forbes magazine this year. So, in fact, I mean, if you were to survey folks in this room, most of us would put our hand up to say, how many of you received 2 or more letters indicating that your personal information or some information somewhere has been disclosed. So I think as a population, consumers, whether they're patients or are doing online banking, we've become numbed to this incessant daily deluge by the media of these breaches, these things have occurred. So honestly, I would challenge this notion that reputationally that's somehow driving consumer behavior. I don't see it.
I would probably agree with you, and I would also note that when we were having discussions with HHS about the breach notification rule, we did talk about notification fatigue. There's a bleeding over from the financial sector and Graham Leach Bliley and all that, but also we know that some of these breaches that must be reported to the patient are minor, and there was no harm done. And that's where the harm threshold discussion came into play with the breach notification rule, and the notion that if you notify patients about everything, there will be notification fatigue. Privacy advocates don't agree. They feel patients should be able to decide that for themselves. There's this whole debate, and we don't really know how much that contributes to the fact that nobody, people are not generally, storming the gates over these breaches. So there's a balance to be had, and truthfully, HHS is still considering that harm threshold portion of that regulation to this day. So that's, I think you've got some good points there.
I mean, that whole risk of harm threshold is still something of an enigma, to the community. But I want to say thank you.
Yes, sir. Thank
Yeah.
you. Thanks for the question.